Good afternoon, everybody. I'm Sarah Dash, President and CEO of the Alliance for Health Policy, and I want to welcome you to our webinar on the immediate and lasting impact of COVID-19 on children. For those who are not familiar with the Alliance, welcome. We're a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. The Alliance for Health Policy gratefully acknowledges the Children's Hospital Association for their support of today's program. You can join our conversation on Twitter using the hashtag AllHealthLive and follow us at AllHealthPolicy. We want you to be active participants, so please get your questions ready. You should see a dashboard on the right side of your web browser with a speech bubble icon that has a question mark on it. Please use that to ask any questions that you may have throughout the broadcast, and we'll address as many as we possibly can. Additionally, you can use that if you're having any technical issues. Check out our website, allhealthpolicy.org, for background materials, including the panelist slides. A recording of today's webinar will be made available there soon. According to the Children's Hospital Association and American Academy of Pediatrics, as of last Thursday, July 30th, children represented nearly 339,000 cases of total reported COVID cases. And children are at the intersection of so many of the questions we are grappling with as a society, from understanding the science of this virus to the social and psychological impacts to serious questions about the safest ways to reopen schools and businesses, and to underlying questions about health equity. I'm so pleased today to be joined by four outstanding panelists to discuss the specific impacts posed by COVID-19 for children's physical, mental, and social health in the short and long term. Let me introduce them now. First, we will hear from Dr. David Rubin, the Director of the Policy Lab and Director of Population Health at the Children's Hospital of Philadelphia. Dr. Rubin is a leading children and family advocate in health policy, a practicing primary care pediatrician, and a professor of pediatrics at the University of Pennsylvania. Next, we will hear from Dr. Tamara Coyne-Beasley, the past president of the Society for Adolescent Health and Medicine, and currently the Darrell Dawkins, MD, Endowed Chair in Adolescent Medicine at Children's of Alabama Hospital. She also serves as Division Director for Adolescent Medicine, Vice Chair of Pediatrics for Community Engagement, and Professor of Pediatrics and Internal Medicine at the University of Alabama, Birmingham, and Children's of Alabama. Next, we'll hear from Dr. Gary Blau, the Executive Director of the Hackett Center for Mental Health, a regional center for Meadows Mental Health Policy Institute. Dr. Blau previously served as Chief of the Child, Adolescent, and Family Branch of SAMHSA for 15 years. And finally, we're pleased to be joined by Dr. Wendy Price, President of the National Association of School Psychologists. Dr. Price has over 20 years of experience as a school psychologist, serving students through assessment, counseling, and consultation, and supervises school psychology interns, as well as providing mentorship. Panelists, thank you so much for joining us today. We'll hear from each of you, and then we'll get into our audience Q&A. Let me now turn it over to Dr. David Rubin.
Yeah, thanks for having me, everyone. I'm just going to make a couple comments during this period, just so we can leave time for Q&A, so I can hear from our my distinguished colleagues and our colleagues on this call. But just to start, our team at Policy Lab back in March and April began modeling the forecasts for what has now grown to over about 750 counties across the United States, representing about 80% of the U.S. population. And we started this endeavor of doing county level forecasting because while we were all preparing for the sheer magnitude of what was about to happen through national models, we also knew that we needed to reopen communities as quickly as possible and as safely as possible, including schools, getting people back to work, et cetera. And that in order to do that, we would need to inform that response by much more locally crafted models that has now led to this modeling that we're doing. If you go to the next slide, and for those of you who want to visit these models, go to policylab.chop.edu. You can see a nice map of all our counties, and you can click on your individual counties, but the projected cases tab is really what can allow you in your home state or your home counties, particularly more populated counties, to be able to see what's going on. We are now up in all 50 states and the District of Columbia, and so we have a fair representation of what's going on around the country. But if you go to the next slide, these are what the projections look like, and I just want to describe a little bit about why our projections have been so valuable. not just to my own state and to our region, but to many other states and certainly the coronavirus task force. When you look at our projections tab, we have both the cases and then we also have what's called the R estimation, which I'm not showing here, but that's your transmission rates over time. The models look about they're updated every week. There'll be a new model update out tomorrow. But what you'll see in our models is that the actual rate of growth in cases or the transmission rates is the number one uh, um, contributor to the model. So if you're growing, you're likely going to have a growing forecast. Now, we alter your forecast based on the amount of social distancing people are doing. We measure what's called visits to non-essential businesses like hair salons and restaurants and retail stores in our model. We also look at your weather. We look at your testing positivity rates. We look at the size of your retiree population, how crowded your living conditions are within your counties, what the population density is there. County to grow along the trajectory that they've established over time, which is to say we don't assume Philadelphia is going to be like New York or is going to be like Sacramento, California, or Indianapolis, Indiana, for example. And because of that, because we're updating every week, we can see things that are very subtle and we can see the way this has been shifting. And our overall assessment right now of the epidemic is we're fortunate to see finally, after what has been a very difficult summer, some evidence of softening in Arizona, California, maybe even areas of Texas and Florida. The South is very much still having a very difficult time controlling the widespread transmission that we're seeing throughout that area. But as those areas begin to subside, there can be this false sense that things are getting a little bit better, but we're seeing continued risk now really moving. I would think of this as waves. And the wave has now been moving over the heartland and into the upper Midwest, up through the mid-Atlantic. And now I'm concerned that as we try to get some schools reopened here in the next few weeks, we're going to see increasing case counts in many areas of the Northeast region. This is Philadelphia's curve, and we're clearly seeing it there. Most metro areas have now gone to online learning. Particularly the city areas, which is a huge tragedy. I think we missed a real opportunity to talk about the sacrifice this summer, not just of preventing hospitalizations and deaths, but assuring the safe opening of our schools. When we think about and I'll just close with saying, when I think about the school reopening plans, we know fairly confidently now that symptomatic children are going to transmit. They carry the virus. Fewer kids will be symptomatic. They're less susceptible, particularly the youngest children, than adults. They're less likely to have severe infection, but they will have some infections. And when there's high community burden, you're going to see more infections in kids, and the more symptomatic kids there are, the likelihood of spreading events in school environments is there. We've seen major outbreaks in a camp in Missouri and a camp in Georgia over the summer. That confirms that where disease burden is high, we're going to see outbreaks. So the safest way to reopen schools is to get case counts down. And you're going to be hearing a lot about testing positivity being much lower in order to do that. And once testing positivity, you can get it down below 5, below 3%, depending on what your state leaders and your departments of health are telling you. Then you have an opportunity to kind of use your mitigation plan. And the foundation for a good mitigation plan in schools is really number one, assuring that you keep sick kids and teachers out of the school by symptom checks and looking for exposures. The fewer symptomatic kids there are in the school during the year, the less likely you're going to have a spreader event. And then once they're in the school, assuring that there's a fair amount of physical distancing. We have stood at Policy Lab behind the recommendation of 6 feet between desks. I know a lot of districts don't have that facility, but that 6 feet is based on knowledge about respiratory viruses like the coronavirus that spread through respiratory droplets. The further you distance kids, the less likely of spread you're going to have. And then using a masking effectively, particularly with your teachers and particularly with the kids in transition between classes. If you achieve a good bubble for kids and your transmission rates are down in communities when they sit at their desk that's nicely distanced from other kids, there may be opportunities when transmission rates are low to remove masks, but unfortunately in our country, it's very hard to identify any areas right now that would meet those criteria. A focus on hygiene and disinfection is going to be critically important as well, and then supporting efforts to improve ventilation, depopulating the classroom, and assuring that, that you've kind of thought through the different permutations of what I call the moments of transmission, that the teachers are spread out so they're not all congregated in a small lounge because of the likelihood of them spreading amongst themselves. And so we can go into a lot more during the Q&A period, but I'll end my comments there to say we're in a very difficult position. We've lost a moment here to try to get our schools as open as we could. But I hope that we're going to regain some opportunity with some of the tightening restrictions per the task force recommendations, and with the limited travel that people might do after Labor Day to try to get some case counts down here in mid-September, maybe revisit some discussions about opening some schools safely.
Great, thanks, David. We did have a question from our audience already, and since it's a quick clarifying question, I'm going to ask you, the data that you were showing, was that total or pediatric forecasting only? And can you comment a little bit on that?
Yeah, those are total daily case transmission within these counties, and so they're not disaggregating pediatric from versus adult in that data.
Okay, great. Thank you, David. So now I am pleased to turn it over to Dr. Tamara Coyne-Beasley. Tamara, take it away.
All right, well, let's go ahead and go to the first slide. And I'm going to talk about adolescence, which is actually a part of childhood. Childhood transitions into adolescence. And it's important to talk about adolescents because they make up about 25% of the population. And when we look at among all age groups in the United States, adolescents and children are the most racially and ethnically diverse among all groups. It's also important when we think about adolescence to understand that most people consider that to be the age range between 11 and 24. But it is a critical developmental stage as young people transition into adulthood. There are several important developmental tasks that must be completed, such as developing and applying abstract thinking, adjusting to a new sense and physical sense of self, and developing stable and productive peer relationships while also striving for independence and autonomy from one's parents. It is also during adolescence when young people adopt a personal value system and develop their own racial, ethnic, social, sexual, and moral identity among a world that might provide conflicting and also non-affirming messages. Adolescence is also important because it's a period of brain plasticity and growth. And it's because of brain plasticity and the chemical and physical changes that adolescents are particularly susceptible to stress. And you'll hear about this more from other presenters. They're also very susceptible to the environment. During adolescence, people will also develop habits and have experiences that impact their physical, psychological, and social health and well-being. And these experiences, as well as the outcomes of these experiences, can be transmitted into adulthood and can even be transmitted intergenerationally. So the next slide allows us to actually look at a framework for how some of these experiences, which can be positive or negative, can impact individuals. They're called the social determinants of health, which are the conditions in which people are born, live, work, or age. They are shaped by the distribution of money, power, and resources. And they account for an estimated 60% or more of health-related outcomes and are largely responsible for health inequities. So let's consider if an adolescent and their family has poor or negative experiences, such as unemployment, inadequate housing or transportation or safety, if they have low educational attainment, poor access to food, particularly healthy food, if they experience discrimination, stress, or low access to quality care, their health outcomes are negatively impacted and can result in increased morbidity and mortality, as well as decreased life expectancy and health status. So let's take a look at the next slide, which gives us another opportunity to describe how people characterize childhood experiences. Adverse childhood experiences and ACEs, I will just talk about briefly because another panelist will talk about them more in depth. But I want to call your attention to the second to last category, which is adverse community environments. Notice that you have systemic racism listed here among the other variables. But I want you to remember that one of the things that I told you is that the developmental task of adolescents is to actually help them develop their social, racial, ethnic, gender, sexual, and religious identities. So when we look at the other adverse childhood experiences that they experience through, as exemplified in the adverse cultural exposures, you can see that these exposures actually have an opportunity to deleteriously impact young people. And so these include things like homophobia, racism, ageism, ableism, sexism, and classism. So let's go to the next slide. Due to the current racial injustice and disparities highlighted and exacerbated by the COVID-19 pandemic, I thought it would be important to discuss the impacts of racism as an example of the immediate and long-lasting impact of children and adolescents. So as you can see here, we talk about one manifestation of racism, which is discrimination. We can see it can have multiple impacts. However, we'll talk first about the denial of goods and services, as well as psychological stress and assault. And as you can see by the bidirectional arrows, that these things can go in multiple directions. The denial of goods and services can lead to poor living conditions, as well as decreased quality of not only healthcare, but also schools, as you've heard already mentioned. But it can also lead to psychological stress, which can provide psychological symptoms. It can also lead to negative coping behaviors and psychological stress responses. And those of us who are in the medical profession may describe this as an allostatic load. Taken together, all of these things can have significant mental health as well as psychological or physical outcomes, including anxiety, depression, substance use, post-traumatic stress disorder, but even cardiovascular disease, diabetes, and decreased birth weights and blood pressure and physical injury can also occur. Next slide. But I want you to know that the disparities that we see during COVID are not new, and that history actually shows that severe illness and death rates tend to be higher for people of color at all times, but in particular during public health emergencies. This is related to longstanding systemic health and social inequities. And people of color throughout COVID have had higher rates of hospitalization and death. What are the long-term complications and implications or long-lasting impact for our children and adolescents, particularly those of color? They also are disproportionately having the adverse childhood experience of losing a parent, a grandparent, a loved one, or a community member. Next slide, please. Why do racial health disparities exist for many adolescents and their families during COVID? Some of the things are listed on the slide and can be characterized into living conditions, work circumstances, and health circumstances. To list a few, many people who are of color live in densely populated areas with racial housing segregation, as you heard our last panelist talk about. And this racial segregation can lead to health conditions that actually exacerbate during COVID, such as asthma. When we think about homes on reservations where our Native American populations live, or homes in the Black Belt that may lack incomplete plumbing and an inability to wash their hands and have proper hygiene. They may also live in multi-generational and multi-family households, making it hard to quarantine. And we also know that they are overrepresented in jails, prisons, homeless shelters, and detention centers, and that in all of these facilities, there are higher rates of COVID infection and death compared with the general population. So what about working circumstances? They're more likely to be an essential worker. They could be in healthcare, but they can also be low-wage workers, such as in meat packing plants, grocery stores, cleaning services, and factories. And they may actually need to continue working in their jobs even when they're sick because of their dire economic circumstances. And they may not have the luxury of having sick leave or childcare. On average, people of color earn less than whites, have less accumulated wealth, and have higher rates of joblessness. This clearly leads into some of the health circumstances where they may be more likely to be uninsured, may not receive health care because of language barriers or distrust, may actually experience higher rates of comorbid conditions like diabetes or cardiovascular disease, which can lead to higher death rates when they do contract COVID. And then, of course, there's the racism, stigma, and systemic equities that undermine not only prevention efforts, but increase levels of chronic stress and toxic stress that leave the body vulnerable. Next slide, please. So when we think about potential public policy ideas for consideration, I actually have listed a few here. And things like the Affordable Care Act ensures that people can try to get health care. The CARES Act actually addresses some of those issues related to the social determinants of health, such as protections against evictions and enhanced unemployment benefits. You can see a variety of things here, including social, criminal justice, and police reform. But one way to summarize the types of policies are needed are policies that promote a living wage and equity, as well as eliminate disparate living, working, and health conditions. And when we think about developing policies, it's important for us to look at it from a socio-ecological model. We need policies that are not just directed at an individual, but at an interpersonal level. Policies that impact communities and schools, as well as organization. And then the last, the outer ring, which is orange, reflects society. So the next slide, please, my final slide. I couldn't actually participate in the legislative and policy forum without honoring what I feel is one of our greatest legislators, Congressman John Lewis. In his posthumous essay published in the New York Times last Thursday, he reflected on his own adolescence and wrote, "Emmett Till was my George Floyd. He was my Rashad Brooks, Sandra Bland, and Breonna Taylor. Till was 14 when he was killed, and I was only 15 at the time. I will never forget the moment when it became so clear that he could easily have been me. In those days, fear constrained us like an imaginary prison, and troubling thoughts of potential brutality committed for no understandable reason were the bars. The COVID-19 pandemic and the racial disparities it highlights is a crisis within a crisis. Not only does it give us the opportunity to protect and prevent and heal our country and its children and adolescents from the immediate and lasting impacts of COVID, but to also heal our nation and prevent its children and adolescents, our future, from the immediate and long-lasting impacts of the ravages of racism and other isms that separate us." Thank you.
Thank you so much, Dr. Coyne-Baisley, for that presentation. We really appreciate it. And we're now going to turn to Dr. Gary Blau. But if you're listening and you have a question, don't hesitate to send that in. We're already getting some questions in from our audience. Gary, go ahead.
Great, thank you so much. And thank you all so much for joining this webinar today. First, let me start off by saying that I hope that you and your families, your coworkers, and your friends are well. I'm honored to have the opportunity to speak with you today. And I think that what we're trying to do is to take sort of policy issues and then like Tamara was saying, to distill that into some very specific issues that are happening. And my role for today really is, and you can advance the slide, please, is to talk about the relationship of COVID, specifically around the mental health issues for children. And I'm going to talk about the traumatic reactions that we're experiencing and some of these underlying factors. And then I will talk a little further about the ACEs study and the impact that this has potentially long term. I will share, today I represent the Hackett Center for Mental Health, where I'm the executive director. We are a regional center, next slide please, of the Meadows Mental Health Policy Institute, not too long established, where we are in, I'm located in Houston, Texas, and my agency really does envision Texas to become a national leader in treating people with mental health needs through our work as an independent, nonpartisan, data-driven policy organization. So thank you for this opportunity. Next slide. And prior to this, I was actually 15 years, well, 25 years in government, 10 with the state of Connecticut in the Department of Children and Families, and 15 with the Federal Substance Abuse and Mental Health Services Administration. And so talking about COVID's effect on children's mental health, please, next slide. I think it's important that we take a trauma-focused lens when discussing this, and importantly, of course, trauma, and as it has been defined by my former agency, SAMHSA, is really about the events that occur, or a series of events that create a set of circumstances that is experienced by the person as either physically or emotionally harmful or threatening, and that can have lasting adverse effects on the person's functioning. And that is across a whole realm. You know, children, in many ways, I learned this in graduate school, children can be thought of as PIES, P-I-E-S, physical, intellectual, emotional, and social/spiritual type of beings. And that is sort of what's happened to children in the course of COVID is not unlike other kind of adverse experiences that we've been discussing. And this one, however, in contrast to, say, where I'm living in Houston, the effects of Hurricane Harvey, or the terrible tragedy in the shooting at Santa Fe High School that have a defined or finite period, this seems to have, goes on and on and on, and particularly around quarantining and stuff. And in trauma, it's really important to not talk to young people about what's the matter with you. It really is about this idea of what happened to you, and that the behaviors that we are often seeing that can occur in children are the result of adaptations to trauma, and that it's not just that kids are bad or anything like that, that they're actually experiencing traumatic events, and then that affects them both physically and emotionally. And in fact, as we know, traumatic experiences actually change the way that your brain functions. And so through things like MRIs and stuff, that you can tell the difference in a child's brain as a result of trauma, and that healing ultimately happens in the relationships that are developed. So next slide, please. And I talk about this, and SAMHSA has historically talked of these 3 E's, and the events that cause trauma, and how you experience it. So the same event may not be experienced by children or adolescents in the same way. It really is a personal understanding of this, and I think it's important and continues to be important for all of us to recognize that children that are having to be quarantined, that are missing school, that are struggling with the loss of activities, the loss of being involved with friends, sometimes even the loss of family members as a result of COVID. This can be incredible adverse experiences that result in trauma kinds of reactions. And again, those reactions can be across the gamut of childhood experiences, be that social, emotional, or physical. So next slide, please. It's also important that there can be, and this is really developmentally different across the different stages, and we can talk further about that, but in a general sense, you can look at children's responses, their behaviors, their emotional reactions, some of their physical things, as the things that are manifested because of the trauma reaction. So we have different ages that are, young children that may have, trouble sleeping, or looking at sort of destructive kinds of things, or older kids that might use drugs or blow up or start fighting. And these are things that happen across the developmental stages. And it's really important that whether kids are going back to school or counselors, and take this kind of a lens, because really we need to understand these trauma responses, again, not about what's the matter with you, but what's happened to you. What are these kinds of events that really resonate to the point where a child is acting out and is having some kind of difficulty, maybe challenges with their bellies, or trouble concentrating, or fears that are manifesting themselves. So this slide really does help us to understand that these are behaviors that are the result of traumatic experiences. So next slide. It was mentioned before, and I think it's important for us to focus on this idea of adverse childhood experiences. There can be many kinds of adverse experiences, whether it's things like significant abuse or neglect, or terrible experiences with child victimization of some sort. And I also, I think that what we've done at the Hackett Center and the work we've done around Hurricane Harvey and Santa Fe is to understand that specific events, and COVID is certainly one of them, can really be identified as this kind of an adverse experience that gives rise to trauma. And in the Kaiser studies, you got to understand that that they looked at 17,000 members and talked about their experiences that they were having now, and looked at their varying experiences in childhood as far as their traumatic responses are concerned. And really what was found, and Kaiser, to their credit, is actually doing a new study around this to see if the same kind of things are happening, but multiple adverse experiences sort of are cumulative and give rise to negative outcomes. So the more adverse experiences you have, and the more intensity that is experienced, the more negative outcomes you're going to have. So for example, you can see on this particular slide that if you have 4 or more adverse experiences, you're going to have a higher likelihood for depression, higher likelihood for using drugs or smoking. The real key to this is that you can also have higher likelihood of many physical kinds of issues as well. Cardiovascular disease is a great example. So young people that have had many and multiple adverse childhood experiences have later in their adulthood have higher rates of things like cardiovascular disease, diabetes, lung disease, and of course other things like suicide. These are just framing it around. The good news is that we can mitigate these impacts, but it's important to understand where these impacts are coming from. Next slide, please. So right now, our children are experiencing these effects. Short term, certainly irritability, anxiety, isolation, the issues that are happen because of school. And our next speaker is going to talk about the issues related to school functioning. We also know that there's pent-up demand without children being, seen in various forums. We don't know that that they may be having issues that we need to address around child abuse or other kinds of victimization. And then the long-term impacts that we know are widening this education gap between folks that have resources versus those that don't, in terms of poverty issues, and that we're then going to see increases in diagnoses related to trauma, like post-traumatic stress disorder, like significant depression and significant anxiety. Next slide, please. And the bottom line here come from a former colleague and good friend, Dr. Lark Wong at SAMHSA, who said that really the bottom line is that kids that are too sad or too mad can't add. And that is really a phrase that we like to talk about, that it's important to address the mental health of youngsters in order for them to do well, to perform well, to do better in school. And that we also know that that young people, that ACEs are more prevalent for children of color, children living in poverty, and young people that have LGBT status. That we just know that obviously are having more potential for adverse experiences. And final slide, please. So our policy options that we are focused on when we're talking about getting kids health, we're talking about expanding and continuing telehealth, because that helps us with capacity and access. It involves engaging our pediatricians and our pediatric providers in terms of collaborative care, of integrating physical and mental health care. That's where kids go. Families, 75% of families take their kid to their pediatrician when they're concerned about a mental health issue. We know we need to do more around evidence-based practices and measure care more. And as Tamara said, we need to address health equity kinds of issues. So that's sort of a nutshell about what's happening with the mental health of our children today, and some ideas for the future for how we can impact it in a positive way. So thank you very much.
Great, thank you, Gary. And if I could just real quickly ask you to clarify something that came in from the audience. Someone who asked what PIES stood for, if you could just super quick clarify that for us?
Sure. PIES was just an acronym that I used as an easy way to understand the importance that we think of a whole pie and then we cut it into these segments for children. It's physical, intellectual, emotional, and social spiritual. And that really frames out the various spheres of development and sphere of functioning that children have.
Great, thank you so much. So great, so taking us now to the level of the schools and school psychologist, Wendy Price. Go ahead, thank you.
Thank you. So I'm representing 25,000 school psychologists across the country and in 28 different countries. I'm the president of the National Association of School Psychologists. And for those of you that don't know what or who a school psychologist is, next slide, please. We are school workers who are uniquely qualified members of school teams. And we have a broad range of skill sets, and we really have expertise in mental health, learning, behavior, and we try and help children succeed academically, socially, behaviorally, and emotionally. So that's a wide range of things that a school psychologist can do. And we tend to work in concert with other mental and behavioral health professionals in the schools, such as school counselors, school adjustment counselors, school social workers, school nurses. And we really partner with families, teachers, and administrators to create supportive and healthy, safe learning environments for students. And a school psychologist's role could also include assessment for learning disabilities, so doing testing through the IEP process. We do crisis work, individual and group counseling, and consultation. So for those of you that don't know what a school psychologist does, I urge you to reach out to your child's school because they likely have one, maybe not full time, and I'll talk about ratios in a second. Next slide. So what we know, and the thing that I believe that parents are the most concerned about in terms of coming back to school, is the known effects of what COVID has done to our students, our children. And number one is, perhaps loss of learning, because everybody was doing virtual kind of academic work from March on. And it was new territory. Nobody really knew how to deliver the same sort of academic and social emotional supports to children via telehealth. So they weren't getting the same one-to-one instruction from teachers that they had been getting previously. So people are concerned about loss of learning. There's an increase in level of stress, as some of my colleagues have alluded to before me, mental health risks, including trauma, and that's for students and staff. There's a higher risk for students with disabilities, our English language learners, our LGBTQ1-2S children and youth. And there's also increased family stress and instability that comes with financial fragility. As mentioned previously, there's might be some grief and loss of family members or close friends who have died of COVID. And there really is glaring inequities on the impact of communities of color. So the compounded trauma of systemic racism and violence against Black communities and other people of color. So we clearly need federal guidance for schools regarding how we're going to meet the students' needs, particularly with regard to special education. Our kids in the substantially separate classrooms, kids with intellectual impairments, Down syndrome, kids that may tend to go to school year-round and have an extended school year. And the other impact is inadequate funding and staff resources. So for school psychologists, we're being asked to do more and more with less and less. And that also goes for our teachers and our administrators. Next slide, please. So addressing the social, emotional learning and mental health needs of students and staff. Schools operate within multi-tiered systems of support, MTSS. And anybody that's worked in a school would probably recognize this triangle. It's a response to intervention MTSS model. And I'm going to be talking a little bit about the tier 1, which is all students. And it's a universal core curriculum that every student has access to. And tier 1 is the level that everyone participates in. So there may be a screening for reading at the beginning of the year, in the middle of the year, and at the end of the year to make sure that kids are reaching benchmark opportunities and levels. And this may include evidence-based classroom lessons, morning meetings to check in, see how the students are doing, check in, check out. There may be advisory periods where a school counselor may check in with a student to make sure that they're in line to continue on the right path scholastically in terms of the way that their curriculum is made. And it may include peer buddies. I'm a school psychologist at a regional high school on the South Shore of Massachusetts, and we try to do as much tier 1 preventative and proactive interventions as we can so that we're able to hit more students, educationally speaking, with proactive and preventative supports so that they don't have to be kicked up to tier 2, which is individual and small group counseling. We tend to look to help a specified number of people that are not able to reach potential in tier 1. So they need additional supports. Next slide, please. So access to school mental health professionals. I've got some recommended ratios here. The school psychologist ratio comes from NASP, my organization. The other ratios were found in other areas of expertise of school mental health professionals that work. So school psychologists, the recommended ratio from NASP is 1 school psychologist for every 500 students. In my particular building, I'm very, very fortunate at Whitman-Hanson to have 2 school psychologists for 1,200 students. So we're a little bit over the ratio of 1 to 500, and we have 1 to 600. However, we also have many, many other school-based mental health professionals, such as school counselors, social worker, and school nurses who help with our behavioral mental health supports. School counselors, the recommended ratio is 1 for 250 students, and that's the same as school social workers. And school nurses, it's 1 to 750 students. However, the lack of funding and budget cuts to schools and education means that many schools have much higher ratios. For example, in some districts, they might have 1 school psychologist helping 5,000 students. And this is all tied to funding. This is all tied to grant writing. This is all tied to budgets. Next slide. So our return to school will not be a return to the school norm. And, right now, school districts are hammering out one of 3 different type of educational platforms that they may be accessing. One is going back to school full-time in person, and what does that mean for meeting the social emotional needs of students and their safety. There could be a hybrid model that is you go a few days and then you do the rest online learning at home, and different teams are rotated in and out, or it may be completely virtual. And so what does that do to the impact of our social emotional needs of students when they're not able to see their friends? And so I've included, next slide, some resources. I encourage you to go to the NASP website and download some of these excellent resources, because we certainly can't tackle everything in the 5 to 7 minutes that we are allotted. But I encourage you to look at NASP for additional resources. Thank you.
Great. Thank you, Wendy. And hello. And I'm going to ask our panelists to turn on their cameras so we can have a discussion. Great. Thank you all for that terrific discussion. We're going to go to 1:05. So we're going to take about 15 minutes for some questions. So let me kind of ask the question that I think is on a lot of people's minds. I mean, David, you know, going back to your presentation, you talked about, yes, kids can spread this virus. There's also a strange new syndrome called MIS that maybe you could spend a minute talking about. I mean, people are people kind of afraid for their kids' lives or the lives of the teachers or those that the teachers may come into contact with. Let's just talk about the physical health and the epidemiology for a second. And we got a question from the audience about sort of age ranges. You know, is there a difference in terms of the spread between kids who are under 3 years old or older? Give us a little bit of a sense, David.
Well, we know that the kids can carry the virus. You know, I think the younger the child is, the less susceptible they appear to becoming symptomatic with the virus, which likely makes them less contagious. This is not absolute. I do think that adolescents, both because of behavior and because of the fact that they appear to carry this virus and become symptomatic in similar rates to adults, it places them at some higher risk for symptomatic transmission. Look, the risk of severe infection is lower in kids. It's also lower in kids with special needs. You know, I was a little bit surprised when I saw the CDC list for parents talk about, does your child have an underlying health condition that makes them more prone to severe COVID illness? Well, we haven't seen that actually in our children's hospitals. Even our young kids with special needs or asthma or other types of underlying chronic health conditions, kids with sickle cell disease, kids with cancer have not gotten really sick disproportionately like we see in influenza season, for example. But that said, some kids will get really sick. And one of the syndromes we described this summer, it's a rare syndrome, but consistent with this immune-mediated response and coronavirus, the MISC is sort of a variant of Kawasaki's disease with very high fevers, cardiac dysfunction, often coronary artery abnormalities, others problems with blood pressure, shock in a lot of our kids. It seems to be responsive to the medications we use for Kawasaki's disease, but these kids are extremely sick. It's just very rare. So you take advantage of the fact knowing that kids are at less risk for severe infection. It gives you some opportunities to open, but they transmit. And so, you know, and kids don't live in bubbles. They rely on parents and grandparents every day. They rely on their teachers, the school personnel, like Wendy talked about today, you know, that are involved in their daily lives. And there's such a sort of foundational sort of social network for a community that this isn't simply about whether kids don't get that sick. This is about the risk to entire communities that are born by placing kids in large groups in a school. And so that's why I try to contextualize these comments. I don't worry as much about the kids in terms of their overall health, although I qualify that with, we don't know the subtle chronic manifestations of COVID yet. This is still an evolving disease. And whether there'll be chronic health issues later on in life, like coronary artery disease, based on some of the things we've seen with MISC, even in milder kids. But that said, I think we have to think of kids in this idea of a social network for a community. And we want to get, and it should have been a national priority to get these kids back to school safely so that the community could work, so that people could get back to their lives. And I see us as now having missed that mark, but still sort of hoping that we begin to understand what we've lost here. It's a real tragedy that schools are not reopening right now. And it doesn't matter what elected officials are going to do. Parents are not going to send their kids to schools if they don't feel it's safe. Teachers are not going to go into the classroom. Building public confidence that our schools can be safe is extremely important. I'll leave you with one story, which is we were terrified to go back to work in March and April at Children's Hospital. And it's because of the mitigation plans and the safety plans we put into effect for our staff with our masking, our distancing, et cetera, that we have not seen any transmission to our staff And I can tell you, we had nurses, we had our physicians, we had office staff who were all terrified. They all share the same medical and psychosocial complexity that our communities have. And we all feel safer now when we go to work than when we're walking around on the streets. And that's what we want our teachers and our parents to feel when kids go to school. And until we can achieve that, you're not going to be able to successfully open schools.
So a level of public trust and confidence. And actually, just a super quick follow-up, if I could ask you very, very quickly, David. We had a question about, someone from the audience has heard about doctors who say there has been no case of transmission recorded from child to adult. So, how do you get that trust if there's still so much? Is that true?
That's not true.
That's not true. Okay, great. Thank you for confirming that. So let me ask, just one more kind of on the school. I mean, Wendy kind of laid out 3 different scenarios: kind of a full-time return to school, a full virtual, and then sort of an in-between. From the standpoint, Wendy, I'll start with you, and then we can kind of go to the panel. From the standpoint of the full spectrum well-being of kids, whether we're talking about the risk of transmission to each other or to the adults in their household, or their social and emotional, is there any one of those sort of 3 general categories right now that seems like it's going to be the best or the most optimal in terms of balancing those trade-offs?
It really depends where you are in the country and what your levels of COVID are around you. We have colleagues in Montana that, are very small and very rural districts, and they haven't had a single case of COVID, and they're ready to go back. Whereas maybe, Boston Public Schools with, thousands and thousands of students is certainly not ready. And there's going to be challenges for any of the type of going back to school plans that you look at. For in-person, you have to look at the physical safety. As David was saying, 6 feet, you have to have adequate space in between student desks. Kids are going to have to wear masks. We're going to have to look at scheduling of students and supporting the higher risk students and staff. So, for example, a student who may have leukemia, who would be very susceptible. We have to be thinking about some of these higher risk people. We have to think about the psychological safety. As Gary was saying, we have to reinforce a sense of stability and security. We have to allow for healthy social interactions, positive communication between home and school. And we have to identify students who are in more risk of intensive academic and social emotional needs. And also, as Gary said, addressing trauma and other issues. When we're looking at the school's virtual needs, there's continued concerns regarding the inequities in the system. Does everybody have access to wireless or broadband Wi-Fi? Or do they have access to Chromebooks? We'll also have to be monitoring student well-being virtually. There's the mental health and the family stability of kids being cooped up with their family for long periods of time. We also have to think about reinforcing positive relationships between students and staff. I happened to be down in New Orleans when the pandemic hit, and I stayed for 3 months, but I was still checking in daily with the students in my high school that I provide emotional support to, and I was very, very concerned about them. So, I mean, there's just a litany of things that schools are going to have to consider, and it's no one size fits all. It really isn't. And that's what I think is so difficult, because people are looking for the one answer to say, okay, you should do it this way. And it's such a fluid and dynamic situation that what we put into place in September may not be appropriate in January. And we may have to roll back and roll forward and keep being flexible, and really paying attention to the levels around us in our neighborhoods and our communities.
Thanks, Wendy. So let me turn to Gary and then Tamara around the psychosocial impact. And we got a great question from the audience directed at Gary, and Tamara, you're welcome to join in too. You know, can you speak to the reality that perhaps not every child has experienced trauma, and is there sort of a range, you know, of sort of psycho and social impact? And maybe I would add, what can help to promote resiliency in this situation? Can you start with that, Gary? And then Tamara, I'd love to hear your thoughts too.
Sure, I think that these are great questions. So, I mean, first of all, I think one of the issues that we have to grapple with is that there is no right answer. Wendy was talking about that, you know, that we have to address these issues, and it will create a real problem with some of the equity, you know, kinds of pieces. People need their kids need to be in school. They need the socialization. I mean, I worry about my own, and I have grandkids, and you know, about how they can get back safely and efficiently. And so I think everyone is struggling with that, especially for parents who have to work. We know that unemployment is also a major contributor to challenges. My agency at the Meadows Mental Health Policy Institute did a modeling study about for every increase in unemployment rates for percentages, that we can expect increases in deaths by despair, which includes suicide and substance use. And so all of these factors have to be taken into consideration. And at the same time, we have to protect our children and to address how they may be feeling that entire range. So again, this is developmentally important, that a child's range of responses to this may be very impacted by, you know, their age. So you have preschool children that, you know, may experience bedwetting or bad dreams or appetite changes and temper tantrums, you know, all the way through, you know, adolescents who have significant issues with, you know, sort of oppositional kinds of things. And yes, that you know, those kinds of ranges are part of this. My hope, and what I'm, you know, I think as part of the process, is that we have to have our counselors, our guidance folks, our teachers, our pediatricians, everyone that touches on families and children, to better understand what those range of behaviors are, so that we can intervene. This idea of a multi-tiered system of supports, and, you know, for all of our children, we need to be thinking about how do we best, you know, help them with maintaining routines and following proper hygiene. But when they're starting to demonstrate behavioral and emotional problems, then what do we do? How do we intervene, you know, to provide services? Or when is it appropriate to reach out and actually ask for specific kinds of counseling and therapeutic interventions? And that's what I think that everyone is struggling with right now, and what we need to address. So that's sort of again a nutshell of things that we're focused on and that we need to be concerned about.
Thank you. And Tamara, you talked about this idea of allostatic load, which I think kind of goes to what Gary said too, about like traumas or even just adverse events being kind of cumulative in someone's life. So talk a little bit about that, like the range of issues, and again, like what do you think would promote resiliency as we move forward, as, you know, hopefully one day we begin to recover from the pandemic?
Sure. And so when we talk about allostatic load, it's really related to the changes that actually come from a person's body due to chronic stress. So that can be changes that happen in the brain. It can be something that people in the audience might understand. It could be the flight or fight responses that continue to rev the body up. And those have long-lasting, you know, impacts on different parts of the body, whether it be the heart, whether it be the lungs, or even the brain. And I think the thing that's really important when we think about the developmental tasks that young people have, adolescence is also a time where people build resiliency. What hampers resiliency? What hampers resiliency are when people get negative messages about themselves, when there are inequities. And this is actually something that all children, you know, struggle with, regardless of their race and ethnicity, because they're trying to develop themselves and understand who they are at a very vulnerable time period. What helps build resiliency in young people is when they have supportive communities. That doesn't just mean their family, but school psychologists, people in the school, people in their church. But it doesn't really just begin when they're actually adolescents or older children. positive messaging and helping young people to develop a strong sense of self really begins, at infancy. In fact, it actually begins when they're being born, when, right, even before conception, because what happens to a family, and particularly a mother, actually can come transgender through the generations to her child and impacts her. So in fact, if we have a mother who is highly stressed because of the environment in which she lives, the adverse childhood experiences she has, that can epigenetically even change the DNA of her child before it's born. So when we think about kind of how do we build resiliency, it's about a community of resiliency, a community of acceptance, and really a community that helps people to feel good about who they are and to utilize their assets to their best of their ability and to actually help them when they do face challenges. And so it's really about taking an approach. You all talk about first tier, second tier, and third tier, but it's really about a comprehensive approach, realizing that all of these things are interconnected, whether at their community level, whether at individual level, or in society. And so resiliency is something that every young person has the opportunity to develop, but they need the community of supports through many different disciplines and in many avenues of their lives.
Great. Thank you. Unfortunately, we're starting to run out of time, but I do want to ask one last question that if I could ask each of you to comment on very, very briefly. What is one practical step that families and communities, and since we're in a policy webinar, policymakers, pick one, could take right now to ameliorate this situation? If you could just briefly comment on that. And I'm going to start with, we'll start with David and go to Tamara and then Gary and then Wendy.
Sarah, can you clarify? Can you clarify what situation you're talking about?
Clarify what I would like you to one practical step that just in your world that you think could be taken to ameliorate the situation. We've talked about, for example, parents, forming pods with other families. We've heard a number of things that schools and communities and policymakers can do. If there was one thing, if you could wave your magic wand and have people do one thing that would just make things a little bit better, what would that be?
I'll start just saying that in our manuscript that came out in Jam Open Network in the last couple of weeks, people would be surprised by the amount of physical distancing, in addition to masking, that is required to keep transmission at bay. So if I could have one wish, it would be for people to recognize to keep the size of their bubbles small. And everyone committed to just, you called it a pod. I call it just, having a few friends that you spend, who share your level of risk, and trying to spend time in smaller groups until we're fortunate enough. And I do have optimism. I think we're going to have hopefully a vaccine by later winter, but we've got another 6 months to go before we see any relief from hopefully a successful vaccine starting to enter the market. If we keep our gatherings small and we attend to these physical distancing recommendations, this virus won't transmit as effectively.
Thank you. Tamara, one practical thing.
I'm sorry. Yeah, so to add on to that, clearly we got to decrease the burden of the disease in the community, and David outlines really well how that can happen. And so the other thing that is really important, because I think it goes towards thinking about the lasting impacts of this disease. It goes to adolescents, and who really are our future. The majority, a large portion of our population, is really dealing with the inequities that we have in our society that also perpetuate the disease because we're not able to get it under control in the same way which we would if we didn't have these inequities.
Thank you. So important. Gary, one practical thing.
So, I represent a policy institute. So, and from a policy perspective, it's important that we get people services when they need it, where they need it. And so I would really encourage people to fight for the ongoing payment and inclusion in a benefit package for telehealth services so that people can get help when they need it. So I'll leave it at that.
Great, thank you. Wendy, you get the last word.
In terms of schools, I think we need to prioritize meeting the social emotional needs of our students first and foremost, because as was alluded to earlier, when a kid's upset or dealing with some sort of issue up here, there's no learning going on. So we really need to prioritize that, you know, every kid has been out of school. We're all in the same boat, but we really need to be paying attention to the social emotional needs of the kids and the staff and the families we serve.
Great. Well, thank you all for joining us. We're out of time. I know we could have a much longer conversation. We really appreciate you sharing your expertise with us today, and for really bringing a full picture of children's health into the conversation. So thank you. For our audience, we will have a recording available at allhealthpolicy.org later on this afternoon. And again, Wendy, Gary, Tamara, David, thank you for joining us, and thank you to the Children's Hospital Association for making this possible. Have a great afternoon, everybody.
Thank you.
Bye.
Bye-bye.
Bye.